Dear audience, thank you for joining me at my complex exam of my PhD program entitled The Application of Enhanced Recovery After Surgery Protocol to Improve Patient Outcomes After Surgeries. Allow me to introduce myself. I'm András Czébely-Lénárt. I'm a fifth-year obstetrics and gynecologist resident at Semmelweis University and a second-year PhD student. My supervisor is Balázs Lindner. My scientific methodology supervisor is Szilárd Váncsa. Our vision is that every patient will get the best evidence-based care before and after surgeries. That makes our mission to integrate the newest evidence-based routines into clinical practice. Currently, we are working on two different projects. The first one is titled Combined Mechanical and Oral Antibiotic Preparation Reduces Complications in Elective Colon Resections, a network meta-analysis of 43 randomized controlled trials. And the second one is comparing the safety and efficacy between fasting and early oral feeding after bowel resection surgeries. My first project is a systematic review and a network meta-analysis. Infectious complications are quite common after colorectal surgeries. The incidence of anastomosis leakage is between 2 to 10% of the cases, and surgical site infection is between 5 to 20% of the cases, respectively. There are mainly two types of bowel preparation to reduce these complication rates in these types of surgeries. The first one is mechanical bowel preparation, which means drinking large amount of laxative to reduce fecal matter from the bowel. And the other one is oral antibiotic preparation to reduce, in order to reduce bacterial load. However, there is not a widely accepted protocol for standard of care. Departments use conventional routines instead of up-to-date evidence. So that makes our aim to evaluate the optimal bowel preparation methods to be used for elective colorectal surgeries to minimize complications after them. Our clinical question: what is the proper combination of mechanical and oral antibiotic bowel preparation to reduce postoperative complication rates in patients undergoing surgeries with bowel resection? We use the PICO framework. We are focusing on patients with bowel resection. And the interventions are mechanical bowel preparation only, oral antibiotic preparation only. These two combine together, and the comparator is no bowel preparation at all. And we are focusing on postoperative complication rates, surgical site infection and anastomosis leakage as primary outcomes, and 30-day mortality rate, reoperation rate, and organ space infection rates as secondary outcomes. Our hypothesis suggests that combining mechanical and oral bowel preparation in postoperative routines will reduce the postoperative complication rates in surgeries with bowel resections. During our systematic search, we used search key containing three domains. First is the preparation methods themselves, the first two, and the third is the surgeries we are focusing on. We ended up with more than 20,000 results, and we found 89 eligible full text. And at the final analysis, we included 43 randomized controlled trials. Our finished analysis, as I mentioned before, the surgical site infection, the anastomosis leakage, and the organ space infection rates, the 30-day mortality rates, and the reoperation rates. So let me dive into the results of our research. My first figure is the summary of surgical site infection outcomes. Surgical site infection is the inflammation of the resection site or the anastomosis site. If it occurs, it reduces the healing and of the bowel section. We used odds ratios to compare these different bowel preparation methods. As you can see, the mechanical and oral bowel preparation in combination could significantly reduce the complication rates in bowel resection surgeries. You can see my network plot with the direct and indirect comparisons of the different methods. And there is a P ranking score with the The highest ranking is mechanical and oral bowel preparation. So it suggests this is the best approach to reduce surgical site infections. My second figure is the summary of anastomosis leakage outcomes. We use the three same figures. First, on the left side, there is the network plot for direct and indirect comparisons. The p-scores, which also the mechanical and oral bowel preparation reached the highest score, and the odds ratios of anastomosis leakage. And if you take a look at the top row, we can see that mechanical and oral antibiotic preparation in combination could also show statistical and clinical decrease, a significant decrease in the incidence of anastomosis leakage. The strength of our study is that it shows a comprehensive picture for all types of bowel preparation. We have the largest patient numbers compared to other previous meta-analyses, and the heterogeneity of the illnesses were low in our selections. However, there are some limitations. We have only a few number of RCTs comparing combined preparation versus antibiotic preparation alone. And we have lack of information about the surgery type and resection site specific complication rates. However, it is not only our fault, but we saw that randomized control trials didn't really report these site specific complication rates yet. So our conclusion that mechanical and oral antibiotic bowel preparation used together is the best approach to reduce complication rates, and oral antibiotic preparation alone has promising effects. Our implication for practice is this combination method should be used as golden standard. Mechanical bowel preparation shouldn't be used alone, but always with oral antibiotics. And if mechanical bowel preparation is contraindicated, oral antibiotics should be used alone as well. Our implication for research is that research for the efficacy of oral antibiotic preparation alone should be focused on more, and we need more detailed reporting about complication rates specific for resection sites. We chose the International Journal of Surgery, and our article is currently under review. My second project is comparing the safety and efficacy between fasting and early oral feeding after bowel resection surgeries. This is a systematic review and a meta-analysis. Conventional protocols after bowel resection surgeries recommend fasting with administering only intravenous fluids until full bowel function recovery. However, ERAS, which is an up-to-date evidence-based unofficial protocol system, suggests early oral feeding as it reduces the length of postoperative ileus and also the length of stay at the hospital. If we look at the statistics, we can see that the resolution of the postoperative ileus is shortened in the early feeding group, and the length of the stay at the hospital could also be shortened in the early feeding group. That makes our aim to investigate the advantages of early postoperative oral feeding. Our clinical question is, what is the optimal timing for first oral feeding after bowel resection surgeries? We are also using a PICO framework. We are focusing on bowel resection patients after operation, and we are comparing early oral feeding versus fasting. And we are focusing on the postoperative length of the postoperative ileus and length of stay at the hospital after the surgery. Secondary outcomes, we are focusing on postoperative complication rates such as surgical site infection and anastomosis leakage. Our hypothesis suggests that early oral feeding after bowel resection surgeries will reduce the length of the postoperative ileus and length of the stay at the hospital, and could also reduce other complication rates as well. Our clinical implication is to ensure quicker and safe bowel recovery after bowel resection surgeries. For summary, we submitted our first project in this year's August, and we are hopefully finishing our second in this year's December. And for my quote, I always said that a smooth sea doesn't make a skilled sailor, but I would like to expand it a bit. It is the end result that counts. Thank you for your attention.
Congratulations.
Thank you.
On your excellent presentation and research. I'm a dietitian, and I was just wondering, what do you mean in the second study under early feeding?
Mm-hmm. So early feeding means after 6 hours of the surgery, the patient can drink fluids, and next morning they can eat anything what they get. And comparing to fasting, they have to wait until full bowel function recovery. So that's the main difference. It can take 2 to 3 days as well.
Thank you.
Thank you. I also have a question. A nice presentation. What type of antibiotic did they use?
In the first project?
Yes.
Well, they are very different types of antibiotics, but according to the data that we could extract, the most favorable were neomycin and metronidazole, the combination of these two, which attacks wide anaerobe and aerobe spectrum of bacteria.
Okay, thank you so much.
Can we go to one of your plots, one of the figures? Yeah, for example, this one. Actually, you already smartly raised that there were some misbalance in comparing different groups, and that's unfortunate that they didn't do actually certain kinds of comparisons of very little. So does it make actually any problem on such an analysis? Maybe this is the statistics question.
Well,
obviously, I mean, there are many comparisons between some of these, and then there are very few from some others, which are actually maybe the most promising ones.
Well, basically, yes, they were, as we can see, there were few comparisons between, for example, the oral antibiotic preparation and mechanical bowel preparation only groups. But if I know well that our statisticians made direct and indirect comparisons with including, after doing some like regression models or to check the validity of the results of the indirect comparisons, and it was no discrepancy between the results. I know well.
And as we see that here, I'm just curious that what is that, because these are all RCTs, but what is the sample size? So when you draw this conclusion that altogether
it's more than 10,000 patients, so it's 11,800 patients.
So the conclusion is quite strong.
Quite strong, yes.
Okay. So yes. That's then the good side. The bad side is that you had to work a lot, I mean, extracting actually all of this data.
First of all, congratulations for your studies. I have some questions. Could you elaborate a little about surgical site infection? What's the diagnosis? How did you define it? And what was the difference between anastomosis, leakage, and surgical site infection? It was not really elaborated in the presentation.
Yes, if I know well that they diagnosed these two complications with, I think, X-ray, maybe. So surgical site infection is just the inflammation of the sutured bowel sections. That's the anastomosis.
You mean not the abdominal wall, but the bowel?
No, the bowel.
But
bowel
how could
itself.
you diagnose that it's a site infection if it was not a leakage? That's what I want to understand, the difference, because you have chosen this point as one of the outcome. Yeah. So you should define it in your presentation that all of us understand clearly what's this, what's the definition, and what's the difference between anastomotic and leakage. Yeah?
Okay.
I think that's one of the important. One of also the confounding factor, and which side of the bowel was resected. Yeah.
Yes, there was like we tried to do some subgroup analyses with the affected bowel sites. But there were no reporting regarding if it was a right side or left side or a lower anterior resection.
Yeah.
So we couldn't do any subgroup analysis for that, unfortunately.
I understand. And last one for the first study, that you have chosen some complication like the 30 days postoperative, first 30 days mortality. And why didn't you use something like the Clavian-Dindo classification or something similar, like for the surgical complications? So it's not anecdotically or not specifically chosen, but given classification site. Maybe the papers have chosen this one in your.
So the 30-day mortality rate and the operation rate.
Mm-hmm. The secondary outcomes, yeah.
Well, we only focused first on primary outcomes, and then we wanted to expand the project with including secondary outcomes, and we used the same analysis for those results. So I think that's why we didn't use the other methods to compare it or to categorize them, the patients.
And there is only some minor comment for the second, for the errors. You have the PICO mistyping.
Yes,
that's good.
The bowel, yes. Thank you.
Thank you. You like smooth sailing, but actually I think it's worth debating these topics. It's very interesting, your research topic. I think that you will have a lot of reactions from the international podium. For the moment, they say, according to the ERAS protocols, that mechanical bowel preparation is contraindicated, or they suggest against it due to the fact of the disturbance of the homeostasis of the patients, that they will become hypovolemic. You will have a lot of hypotension during the operations, and that will lead to a lot of complications. Inside of that, it's very interesting to see these results on a huge number of patients.
Yes, it is, but we have to see that if we take a look at the mechanical bowel preparation results and the no preparation groups, we can see that there is quite no difference in postoperative complication rates. So if we just think about if we would do the mechanical bowel preparation or not, we should avoid it. But if we combine it with oral antibiotic preparation, there will be a significant difference. And maybe it is because the laxative effect, and it can help the oral antibiotic to reach the further segments of the bowel as well. So maybe this is the explanation of the combination reducing effect.
Yes, that's a good argument. The next step would be that if somebody would like to argue with you, then they would say that the human microbiota is just like a fingerprint for the person. It's very specific. It's very different in elderly than in middle-aged people or in young children. Given metronidazole and neomycin, they will have totally different effect in an elderly patient than in a younger patient, because firmicutes are very frequent in the elderly and they are very rare in the younger ones. And if you have a tumor, then you will have proteobacteria where they don't act usually. So that's totally different microbiota. Not to talk about the One Health concept, that you give antibiotics to the patient, that the stool will go into the surrounding and you will induce multi-drug resistant bacteria very, very soon. How would you defend these results when you consider these things that the microbiota is personalized and they will have totally different effect, and you can also induce dysbiosis, which can lead to ventilator-associated pneumonia. That's one of the things. And the other, regarding the surrounding, that you will let a lot of multi-drug resistant bacteria into the surrounding that will further increase the antibiotic resistance, which is a huge concern in Europe.
Yes, thank you for your question and your comment. Basically, so I think they are not focusing on the personal microbiota fingerprint yet, and they don't choose the antibiotics specifically for the patient or chosen for the patient. But I've read some articles that they try to supply like probiotics after the surgeries to reduce these microbiota persistent microbiota changes after these surgeries. So that's how they try to prevent it. But I don't know, it is always there is two sides of the coin always. To reduce the surgical site infection and anastomosis leakage rates in an elderly patient who has several comorbidities. Maybe it is better to try to lower these rates than try to at first protect his or her microbiome system in the gut. So it's the two sides of the coin, I think, if it's a good answer or if you accept this answer.
Yeah, that's what I wanted to influence this kind of discussion. It's very interesting, and what I would suggest is to go on the long-term effects and have a look at these patients, if possible, and if you have data on the long term as well, because the complications will come not in 28 days, but within three months' time, and that's the other side of the coin, which might worth another good research.
It's interesting that there are some researches that focuses on Clostridium difficile infection after these surgeries, and the mechanical and oral antibiotic combination preparation seems to have no effect on Clostridium infection after these surgeries. So that is also a promising result, I think.
I agree. Thank you very much for the explanation and for the research as well.
Thank you very much.
So congratulations from my side as well. Very important and interesting topic. I'd like to ask also in this realm of one size fits all, should we prepare all the patients the same regardless of the baseline indications? Do you have any data on that? Were these odds ratio adjusted based on indication on the baseline diagnosis of the patient? Is it the same in cancer and in inflammatory bowel disease? Or
yes, this is like at the beginning we decided, so we had quite a homogeneous population because we excluded inflammational bowel diseases. So apart from the previous meta-analysis who included these inflammation diseases, we excluded them to make a more homogeneous population. So that's why I don't know if the inflammation diseases has other types of needs for antibiotics, but for these are 95% of the patients were because of cancer, so tumor resection surgeries.
And were the odds ratio adjusted, used in the model? Just out of curiosity, were they like corrected for confounders? And if the confounders were similar across the studies, the considered confounders?
Like we had a number for heterogeneity on my previous slides, but for the final figures we didn't include them, but it was quite low, the heterogeneity of the patients.
Thank you for the presentation. I have 3 questions, all 3 will be related to this slide, so we can stay here. My first question is that the combined therapy had a point estimate that showed that it was a bit worse than the oral only. Still, based on the p-scores, it seems better. What could be the reason for that?
So the combined...
based on so here the point estimate says that it's 61.
Yeah, because the oral antibiotic preparation didn't reach a significant decrease in surgical site infection rate. So maybe that's why it only scored second on the p-score.
Okay, it's absolutely correct, I think, the answer. The second one is based on your clinical knowledge or based on how you know the results. Do you think that the antibiotic therapy and the mechanical preparation has an additive effect to each other? So let's say one decreases the percentage of surgical site infections by 5%, the other decreases it by just gibberish numbers, 10%. Then the combined would be like a 15% decrease, or is there they just aid each other in?
I think it is. So if we take a look at the mechanical bowel preparation, it seems to have no effect compared to no preparation at all. So basically it has no effect. But combining these two, I think this is an additional effect to each other, because if we take a medicine, an antibiotics, and we add laxatives to it, the antibiotic molecules can reach the further gut sections because of the laxatives, because it fastens up the fecal expellation from the bowel. So I think that could be the explanation of these, combining these two, resulting a significant decrease.
Thank you. And my last question, you touched on my last question a bit. So we can see that basically no preparation or the mechanical has no effect. Mm-hmm. But my question, I don't remember your other results, but only based on these results, it seems like the mechanical has nothing to add to the combined. So is there a chance that the mechanical basically has no effect at all, and in the combined we also see just the effect of the oral part?
Yes, and it was like over the, if I read well the articles, over the last few decades, it was the biggest insecurity to use, or the biggest question was to use the mechanical bowel preparation at all or not, because we mentioned that it causes dehydration, ionic imbalances in the patient, and it is a worst feeling to drink 3 liters of like this worst or this tasteless or bad taste drink. So they focused on that, and they at the, I think 5 or 6 years ago, they could finally said that we can leave mechanical bowel preparation, but the newer articles started to focus on combining these two, and they found out that combining is more effective, much more effective than no preparation. So this is why the combined preparation got very famous, or like they use it a lot. But one interesting thought that in the oral antibiotic preparation group, the articles the RCTs we examined didn't. So the fewest patient was in the oral antibiotic preparation group, around, I don't know, 2,000 maybe, in difference to 11,000. And we can see that it almost reached significant difference. And if I think that if we would do a randomized control trial with no preparation, comparing oral antibiotic preparation with a larger population size, then it could reach a significant difference. So maybe in 5 years we would discuss about oral antibiotic preparation only, without mechanical bowel preparation.
Okay, thank you.
Yeah, I would like to ask you, if you had all the money that you asked for to prepare a study to evaluate the early oral feeding, how would you do it? Because in the ERAS protocol, there are also many other measures that you can take into consideration to prevent complications. So what would you do in the study? And what are the possible confounding factors that you found in the studies that you have already included?
Regarding the second topic, right?
Yes.
Well, if I would have all the money, like
limited.
Yeah, but it doesn't very depend on money, because it's just a decision if the patient gets food next day after the surgery, or we wait until full bowel function recovery. So basically the experience, so the wellness of the surgeon, of course the co-founder factors of the patient can affect the outcomes, the postoperative outcome rates, but it's just a decision when to give the patient food for the first time.
Mm-hmm. Okay, and I don't know if you have seen this new ERAS protocol. It was published in June already about colorectal surgeries. What would your study add to the new guidelines? Because we have a strong recommendation already for having this postoperative nutritional care, and a weak recommendation for mechanical bowel preparation. So what would your study add to this new guideline? Would this be a change in the new guidelines?
Well, I think this is a very robust evidence with the high numbers of RCTs, and we only included RCTs for this study, and there is a significant reduction in the complication rates. So basically, it just strengthens the previous findings in the ERAS protocol to use this combination.
And I would also suggest to include the new ERAS protocol guidelines in the slides, because I didn't see it there. Okay, that was it. Thank you.
Thank you.